Hi, this is Brian Kim. I'm going to share with you this case of a patient who had really a routine standard cataract surgery. And while I was removing the lens material and I was waiting for the INA handpiece, I noticed there was a tiny anterior capsule tear subincisionally. And so I went back and looked at this case over and over and over again. I could not figure out how there was that small tear. But you're going to see as the case progresses and as I'm watching this tear and I'm doing IA trying to clean up the bag, the tear does propagate just a little bit, but not that badly. And I'm going to show you how I'm able to handle that case and the situation and what I did. But really, the point of the matter is you have to always pay attention to every step of the surgery to minimize complications and achieve success. And this is a classic example of that. So you can see this patient has a really huge pupil, which is rather nice. I'm using the corneal marker, which will help me to center and size the rhexis. Using the cotton tip to control the eye, I turn the eye towards the left of the screen, and I make my paracentesis incision first on the right side, turn the eye the other way, making the incision on the left side, making sure the incision is parallel to iris plane, which creates a nice corneal shelf, which will allow me to create a self-sealing incision. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. And these are the Moria microforceps. I puncture the center, which have sharp tips, pull down towards me, and then grabbing the right side of the tear. Using the cannula to control the eye. Go ahead and make the rhexis going around. These microforceps are extremely low profile, and I've noticed very little OVD egress using this forcep. And it's so stable that you have to kind of relearn how to do capsular rhexis. If you're like me, you're used to pulling a little bit towards the center throughout the entire rhexis. But if you do that with this, you'll actually spiral inward. So very little radialization forces with this forcep. This is the capsule fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point to tip down, lift the lens up, tilting it, which allows me to decompress the bag, sweeping under the rhexis edge on the left side and then now on the right side. The lens is a little bit stubborn. It's really a little sticky and it doesn't want to totally spin. Rather than perseverating, I go ahead and stop. Irrigate the surface of the eye, lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. Removing the surface epinuclear material, placing the chopper under the rhexis edge contra-incisionally, pointing the phacotyp vertically subincisionally, fracturing the lens in half. You can see I place the chopper at the epi and endonuclear interface. Placing the chopper around the right heminucleus, hooking the peripheral lens, again at the epi and endonuclear interface, hooking the peripheral lens, pulling it centrally toward the phacotyp, and crushing the lens against the phacotyp, and the phacotyp is acting like a chopping block. Chopping the lens pieces into smaller and smaller pieces, and then emulsifying the lens piece. You saw I was able to gently hook the peripheral lens of that second quadrant and just popping it up out of the bag. Again, the chopper is really the most versatile instrument in this context. It gives you tremendous versatility and leverage to be able to control lens pieces and pulling lens pieces up out of the bag. Trying to gently turn that second heminucleus in front of me. Using some vacuum to help me also. And then getting around the lens with the chopper, hooking the peripheral lens, pulling it centrally toward the phacotyp, and fracturing the lens completely in half. Using mechanical fracturing forces to crush the lens into smaller and smaller pieces, and then emulsifying the lens piece. Using some vacuum to grab that fourth quadrant up, hooking the peripheral lens, crushing it into smaller pieces, and then emulsifying the lens pieces. So again, not a terribly dense lens. This is really a standard type of case. removing some of that epinuclear material. But I'm going to leave that cortical material for the IA. So I take the chopper out, push BSS in, take the phaco tip out, and I want you to pay attention to something. As I'm pushing BSS in, I am surveying the entire case. I'm looking at the capsular rhexis, and look, I notice that there's a tiny tear in the anterior capsule. And I see it. It's hard to see on the screen because I looked back again. But I know in real time I saw a tiny little nick in the anterior capsule. So I'm very careful here. You can see I'm going to be very ginger. I always start subincisional because I know I have to get that part first because that's the hardest part to get out if you have a tear. So I go ahead and take that out first. I start subincisional. I did a little bit of refluxing because I just want to make sure I don't accidentally grab the capsule. And again, I'm trying to peel the anterior cortex from anterior to posterior, which I did a very good job with, but you can see there's some fine lens materials. Again, this is what I've noticed when you're not able to get a freely mobile spinning lens. It leaves this fine cortical wispy material, which is rather annoying. So I'm trying to polish that material off. I'm starting away from me just to make sure I get all that stuff out, which should be pretty easy to do. I'm also polishing the anterior capsule as well. And you can see so far I'm avoiding that subincisional tear, but I know it's there. So now I'm polishing subincisionally. You can see there's cortical wisps there. Polishing subincisionally again. Now remember, I know there's an anterior capsule nick, but I'm fairly confident there's no forces that's going to cause it to split and propagate posteriorly. Again, even if you have an Argentinian flag sign, that typically doesn't happen because when it splits, once that intracapsular pressure is relieved, that capsule doesn't split posteriorly. So you can see here that there now clearly is an anterior capsule tear. It's right underneath my incision. And so this is a question, what are you going to do next? I still have some fine lens material subincisionally. Obviously, I'm not going to be able to remove it like I normally do. And so it's going to require a lot more gentleness and nuance as I try to clean up the rest of the bag. I'm not going to push high pressure into the capsular bag with the BSS like I normally do. But this is the first thing you want to do. You're going to push the capsule leaflets down with the viscoelastic, and you're not going to overinflate the bag. So that's the key. When you have anterior capsule tear, don't overinflate the bag. Just inflate it enough so that it's nice and open. And then you want to push down the anterior capsule tear leaflets down so they're in a more anatomic position. And then I'm using the sweep. You can see I'm very carefully and gingerly and with a lot of control peeling some of that cortical material off the bag. Not applying a lot of pressure on the bag as I do this. And because I know it's an isolated anterior capsule tear and it has not propagated posteriorly, I feel comfortable placing the single piece acrylic lens into the capsular bag. And because the lens opens up very slowly, you have a lot of time to reposition the haptics. And of course, you want to reposition the haptics and orient them perpendicular to the tear. And so this is very important here. You don't want to leave it like this, because then the haptic is going to be encountering and impinging on that tear. So you want to actually rotate that lens more clockwise. You want to have that trailing haptic much more away from your subincisional anterior capsule tear. So you can see I'm rotating quite a bit. And I know now it's not going to be anywhere near that anterior capsule tear. I go in with irrigation off, activate irrigation, gently getting underneath the lens, removing all the viscoelastic from within the bag. And then now that the lens is in the bag, if you do have some fine cortical material, you can use that lens to help tamponade the bag and keep the bag from you as you try to peel off some of that lens material. And that's what I'm doing right here. I'm trying to take advantage of the lens optic and trying to clean the bag as much as I can. And you always want to be mindful. You don't want to do something too aggressively and cause problems. So I go ahead and polish underneath the rhexis edge, making sure everything else is nice and clean. Again, this patient has a huge pupil. It really makes it easier to see what's going on. And you can see my rhexis is perfectly sized and centered. I'm removing the viscoelastic from the anterior chamber, and then I'll hydrate my incisions. Of course, at the very end, you want to make sure you push BSS. Try not to let the chamber collapse as you do that. There's some fine lens material that's caught on the right side there. I'm just gently trying to remove that material. But that's very important. Yeah, I'm just trying to remove some of that lens material that's stuck there. And so remember, when you come out, you want to push BSS. Don't allow the chamber to collapse. Don't ever overinflate the bag with cohesive viscoelastic. When you have an anterior capsule tear, that makes no sense. You could potentially propagate that tear. And you saw it was able to push and tamponade the anterior capsule leaflets down, because if it's sticking up because there's so much OVD in the bag, the capsule's actually tented up. So you want to actually push that back down into the same capsule plane. So go ahead and hydrate my incisions and making sure I reposit the optic back into the bag, and that's the end of the case. So again, multiple points here. Even though I had an anterior capsule tear, I recognized it early. When I took the phaco tip out and I was pushing BSS, waiting for the INA handpiece, I was surveying my rhexis. I'm looking at my rhexis. I'm making sure there's nothing else weird going on in the eye. And I noticed there's a small little nick in the anterior capsule subincisionally. So I was like, okay, I'll wash that and make sure it doesn't cause any problems. Of course, it was there. It was clearly confirmed after I did the INA, but because I was aware of it, I was able to know how to handle it. And then on top of that, I have techniques that are very gentle on the capsular bag, even if there is a capsule tear. Remember, I don't tend to spin the lens in the bag. If I don't need to, I try to prolapse pieces up out of the bag by hooking it with the chopper and pulling lens pieces up. If I have to rotate the lens, I'm very gentle with it. Sometimes I'll use vacuum. Sometimes I'll hook the lens out of the bag. The point is, I'm trying to create as little stress on the bag as possible. And I do that on every single case. And if you do that on every single case, if you run into a case like this where you do have an anterior capsule tear, well, it's no problem because you've already put in place all the protective maneuvers that you do every case for every patient. And so you don't have to modify anything dramatically because you're already performing safe surgery. You're already performing gentle surgery on the zonules, on the bag, and minimizing ultrasonic energy, reducing trauma to the corneal endothelial cells. And so this is why I feel like this is such an important thing to do and learn. And these are principles that everyone should abide by. If you do these things every day on every case, even when things go less than ideal, you can handle it well without much trouble, and you're able to know how to handle these difficult cases, and they essentially become routine cases. This patient did great and saw 20/20 the day after surgery, and there was no issues whatsoever. Again, all of this due to good preparation and acute awareness of the situation at every moment in surgery. So I hope this was helpful to you, and I thank you for your attention.